When we picture an asthma attack, we typically focus on the mechanical narrowing of the airway. Behind that constriction lies a chronic, underlying inflammation. To manage this constant inflammatory baseline, global clinical guidelines rely on inhaled corticosteroids, or ICS. These are recognized as the most effective anti-inflammatory medications for long-term asthma maintenance. While quick-relief bronchodilators offer short-term rescue, daily ICS therapy prevents exacerbations and protects the lung's functional capacity over decades. But how exactly does a microscopic mist, inhaled for just a few seconds a day, exert such lasting control over a highly reactive immune system? To find the answer, we have to travel past the airway lining, down into the tissue, and look closely at a single epithelial cell. The power of these molecules comes from their ability to penetrate the cell membrane and migrate to the nucleus, where they physically reprogram the genetic code. They achieve this through two simultaneous genomic pathways: transactivation, which builds up defenses, and transrepression, which shuts down attacks. When an inflammatory state becomes ingrained in the tissue, chemically reprogramming the cell's genetic instructions is the only way to effectively dismantle the disease. This diagram outlines the molecular mechanism of inhaled corticosteroids. Starting at the top left, the ICS molecule approaches the cell membrane. Because corticosteroids are highly lipophilic, they bypass the need for specialized surface transport proteins. Instead, they passively diffuse directly across the lipid bilayer and enter the cytoplasm. Waiting inside the cytoplasm is their primary target, the glucocorticoid receptor alpha, or GR-alpha. There is also a decoy version of this protein called GR-beta. It cannot bind corticosteroids and acts as an inhibitor, often elevated in patients with steroid-resistant asthma. When the ICS molecule locks into the GR-alpha receptor, it creates the activated ICS GR-alpha complex. This physical docking changes the receptor's three-dimensional shape, causing it to shed stabilizing proteins and become officially active. Once activated, the complex is rapidly transported out of the cytoplasm and toward the center of the cell. Through a process called nuclear translocation, the complex slips through the nuclear pore and enters the nucleus, where the cell's DNA is stored. This entry is the mandatory first step of the process. If the complex cannot reach the nucleus, the drug has no anti-inflammatory effect. In the lower left quadrant of the diagram, labeled transactivation, the cell begins the active transcription of genes that produce anti-inflammatory proteins. Inside the nucleus, two of these activated complexes pair up to form a formodimer. This paired structure binds directly to specific promoter regions on the DNA strand known as positive glucocorticoid response elements. By locking onto these sequences, the drug stimulates the cell's internal machinery to synthesize a fresh supply of defensive proteins. This process generates several key anti-inflammatory proteins, including NXN1, MKP1, and the inhibitor IκB alpha. MKP1 is especially critical. It inhibits MAP kinase pathways, which are major intracellular drivers of airway inflammation. This genomic machinery also extends its influence to other medications in the asthma regimen. By activating the gene for beta-2 adrenergic receptors, transactivation increases receptor density on the cell surface. This protects the cell from the tolerance and downregulation that typically follows heavy use of bronchodilators. In return, long-acting beta agonists trigger cascades that speed up the nuclear translocation of the corticosteroid complex, allowing both drugs to work with greater efficiency. Through transactivation, the cell actively manufactures its own anti-inflammatory defense arsenal from scratch. While building defenses is vital, the drug must also silence existing attacks. We see this in the lower right quadrant, transrepression. In asthmatic airways, pro-inflammatory transcription factors like NF-κB and AP1 are constantly signaling the cell to produce inflammatory cytokines. The ICS complex interrupts this signaling by recruiting a critical enzyme called histone deacetylase 2, or HDAC2. HDAC2 removes acetyl groups from the histones, the protein spools that DNA wraps around. Stripping away these acetyl groups causes the DNA strand to coil tightly and condense. This tightly compacted DNA physically blocks molecules like NF-κB from accessing the promoter regions, effectively turning the inflammatory genes off. A secondary mechanism targets the immune system directly, specifically the T helper 2 cells that drive allergic asthma. The activated complex interferes with GATA3 signaling, which is a master regulator of the allergic response. Blocking GATA3 suppresses the production of Th2 cytokines like IL-4 and IL-5. Without these signals, the recruitment of destructive eosinophils into the airway tissue drops significantly. Transrepression chemically locks away the blueprints for airway inflammation, rendering the cell unable to execute an inflammatory response. Displayed together, we can see how transactivation and transrepression happen at the exact same time inside the nucleus. By simultaneously building up defensive proteins and silencing pro-inflammatory genes, this dual-engine mechanism steadily reduces airway hyperresponsiveness and limits mucus production. Because this cellular reprogramming is so highly efficient, patients achieve significant clinical benefit even from low to medium doses of ICS. This is a slow genomic process. It takes time to rewrite a cell's behavior, making daily consistency far more important than the immediate effect of a rescue inhaler. This deep efficacy is why medical guidelines prioritize ICS as the foundational controller therapy, even for patients with mild persistent asthma. Optimizing this therapy, frequently through ICS-LABA combinations, targets the cellular foundations of the disease to stop the symptoms before they can manifest. Over a lifetime, maintaining this baseline of genetic control is what prevents severe exacerbations and preserves long-term lung function. Ultimately, treating asthma isn't a matter of simply opening the airways. It requires reaching into the nucleus and rewriting the inflammatory code of the lung itself.